This episode of Pupil Pod is supported by Dompe.
Welcome to Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Sila Bal, and I'm really excited to introduce my next guest, Dr. Laura. Dr. Laura is a retina specialist in Dallas, Texas. Dr. Laura, thank you for joining me today.
Thank you so much for having me.
So let's get into the case. This is a 22-week-old gestational age baby girl with a birth weight of 800 grams who is now admitted to the NICU with respiratory distress. She has undergone surfactant injection and oxygen therapy. Retina, Dr. Laura, is consulted due to a concern for ROP. Dr. Laura, when we think about retinopathy of prematurity, what babies and what are the criteria for the babies that we really need to make sure that we screen?
Screening includes performing a dilated exam on all infants with a gestational age of less than or equal to 30 weeks or a birth weight less than or equal to 1,500 grams. And screening also applies to infants who weigh between 1,500 and 2,000 grams or gestational age over 30 weeks if unstable clinically, and that's determined by the pediatricians and the neonatologists taking care of them.
And I think those are such high yield numbers. We really need to remember that for any of our at-risk babies. But let's say that a neonate meets that screening criteria. When do we begin screening those babies?
I usually screen at 4 weeks postnatal age or 31 weeks post-conceptional age, whatever is later. And some hospitals use slightly different guidelines, but in general, the first DFE falls between the 4 and 6 weeks of postnatal age or within 31 and 33 weeks post-conceptional age, whatever is later.
Okay, so just to summarize, we screen babies that are born under 30 weeks of age, are less than 1,500 grams, or if they are older than 30 weeks, but still less than 2,000 grams and clinically unstable. And for those babies, the first exam is within 4 to 6 weeks or 33 weeks of post-conceptional age, whichever is sooner. It's a lot to remember, but these are our highest risk babies. Let's say that we have one of these babies and you are screening them and you do your wonderful dilated fundus exam, which I honestly still to this day don't know how you amazing retina specialists get those good views of the fundus. But let's say that we got a perfect view of the fundus and now we want to stage ROP. Can you review the ROP stages for us and talk a little bit about what you would expect to see on exam and how you examine those babies? Any pointers for the trainees out there?
Sure. So let's go through the stages first. So I actually consider it stage 0. It's how I document it if there's immature retinal vasculature without any pathologic changes. Stage 1 is when a demarcation line is seen between the vascularized and the non-vascularized retina. Stage 2 is when that line develops some height, and that's considered a ridge. Stage 3 is when there's this ridge with extraretinal fibrovascular proliferation on it. And stage 4 is a partial retinal detachment. It's subdivided into stage 4A, which is extrafoveal, and stage 4B, which is involving the fovea. And stage 5 is a total retinal detachment. And we categorize that as open or narrow anteriorly or posteriorly. For example, a common configuration is open anterior, open posterior, and a less common configuration is narrow anterior, open posterior. In terms of examining these babies, it can be really difficult. A lot of these babies are incredibly sick, and don't be afraid to ask for the respiratory therapist to come in, for the neonatologist to come in. I often have multiple people in the exam room with me. Similarly, always mention what the exam is going to be like to the parents if they're there and offer to let them step out. The exam always looks a lot worse than it is. I always tell them it doesn't necessarily hurt, they just don't like the lights, which are extremely bright. I always have the nurses monitoring the monitor closely. A lot of these babies can become bradycardic during the exam, and a lot of them need a lot of respiratory support. The height of the bed makes a big difference for me in terms of just ease at visualizing the fundus. I'm pretty short, so I've had them lower the bed as far as possible, which can be really helpful. And sometimes we actually need to take breaks during the exam if things are looking a little bit unstable. And I always defer to the neonatologist if we need to defer an exam on that day.
That is very helpful. I think as a fellow short female, it's always really great to hear what tips that you have at bedside, especially because we're always kind of contorting our bodies trying to get in the right position. But really just stopping and saying, I need a step stool and I need support, I think is just so important. And for all of our trainees out there, do not be afraid to ask for those things. In terms of staging, so we kind of talked about the different stages, and just for our listeners, it has helped me in memorizing these stages to try to visualize them. Number one, by looking at photos of all of the stages, and that's so important, not only for our testing purposes where we could potentially be shown a picture, but also for our clinical exam to know what you're correlating with. But it also helps me to use little mnemonics. So for stage one, I think of it as looking like a line, and that reminds me of the demarcation line. For two, I think tuft to tuft, they both start with a T. So I try to picture those two together, and then I kind of go from there to stage three, four, and five. But it doesn't stop there, of course, as it never does with these things. They also have zones and something called plus disease. So, Dr. Laura, could you tell us a little bit more about the zones and plus disease and how those work into our staging criteria for retinopathy of prematurity?
Sure, sure. Let me talk about the zones and plus and then discuss how that actually plays into the schedule at which we examine these children after the first DFE as well. So zone 1 is really the posterior pole. It's defined as a 60-degree circle centered around the optic nerve. Zone 2 is from zone 1 to the nasal aura anteriorly and to the mid-periphery temporally, usually to the temporal equator. And then zone 3 is the remaining temporal peripheral retina. Plus disease is retinal vascular dilation and tortuosity of the posterior retinal vessels in at least 2 quadrants. And this can be accompanied by venous dilation of the iris and some vitreous haze. So when we think about when to re-examine these babies after the initial dilated fundus exam, I take into account both the zone and the stage. And again, nothing is perfect in terms of lumping it into everything has to be seen in 1 week, 2 week, 3 week. A lot of it depends on how aggressive the disease process appears to be, if the ROP is rapidly progressing from one dilated exam to the next. In general, any baby with what we call pre-threshold disease that we'll talk about a little bit later that we aren't treating, so type 2, I see them weekly. And anything that appears to be worsening on follow-up, I see them weekly. But a kind of a nice way to think about it is anything in zone 1, I'm going to see in 1 week. Anything in zone 2, I'm going to see in 2 weeks. And things in zone 3, I'll see in 2 to 3 weeks. I rarely extend my follow-ups beyond 3 weeks. So for example, even if there's just immature vessels in zone 1, so no ROP, but the vessels only extend to zone 1, I'll see that baby in 1 week. Any ROP in zone 1, I'll see in 1 week. And then similarly, vessels that extend to zone 2, but no ROP is present, I'll see that baby in 2-week follow-up. Any stage 1 or even stage 2 ROP, I'm going to see within 2 weeks. Stage 3 ROP in zone 2, I still see in 1 week. So that one doesn't fall into the 1 week matches one zone example. Anything that I see in like 2 to 3 weeks is pretty much the vessels have reached almost out to zone 3, or it's stage 1 or 2 in zone 3.
This is so helpful. So now we've heard a lot of really useful information about the screening criteria, the staging, and our follow-up intervals. And we need to get into the treatment or the studies that we have that help guide us in treatment. And the first study is the cryo ROP study, which helped us determine when cryotherapy or retinal ablative therapy should be performed. Dr. Laura, is that correct? It's the cryo ROP study. And can you tell us a little bit more about that and how we stage those patients and when we treat those patients?
Sure. Yes. The cryo ROP or cryo ROP study was as you mentioned, the first major trial for ROP. And it was significant because it defined threshold disease. And they enrolled neonates with a birth weight of 1,250 grams or less. And they applied cryotherapy to the peripheral avascular retina in babies with severe or threshold ROP. And they define threshold ROP as 5 contiguous or 8 cumulative clock hours of stage 3 ROP in zone 1 or zone 2 with plus disease. And this criteria for treatment was later extended to laser treatment as well.
Great. And then next up is the ETROP study, which stands for early treatment of ROP. So this was the one that helped us better understand the best time to treat before ROP turns into a retinal detachment. Is that correct, Dr. Laura? Can you tell us a little bit more about that study?
Right, exactly. So this study, the ETROP study, established benefit of laser treatment in what they considered high risk pre-threshold or type 1 ROP. And they also enrolled babies with a similar birth weight, and they applied laser therapy to the peripheral avascular retina in these babies. So let's talk a little bit about type 1 and type 2 ROP. So type 1 is is zone 1 ROP, any stage with plus, zone 1 stage 3 ROP without plus, and zone 2 stage 2 or 3 ROP with plus. The other subtype of pre-threshold disease, which we consider type 2 that doesn't need treatment, is zone 1 stage 1 or 2 ROP without plus, and zone 2 stage 3 ROP without plus. And I will say those babies that I see with the type 2, the pre-threshold disease that we aren't treating, those are the ones that I'm seeing weekly. And I think in clinical practice, if they are rapidly worsening, they're developing worsening vessel tortuosity, a lot of the time I will treat them, sooner rather than later.
That's great to know. I mean, a lot of times we use these studies as a guideline to help inform clinical practice, and knowing just how you treat those patients and what you do in your daily practice is extremely helpful. And then, of course, the final study, and this one's a little bit of a newer study. We were kind of talking about it before starting the recording, is the GROP study. Dr. Laura, can you tell us just a little bit, a few helpful things about this one and how you expect that this may influence practice in the future?
Yeah, this is really exciting because currently the recommended guidelines are based on this birth weight of less than or equal to 1,500 grams and the gestational age less than or equal to 30 weeks. But there have been a lot of other proposed algorithms that are based on the amount of weight gain and systemic IGF-1 levels, as these are also associated with ROP risk. So, GROP is a new criteria for examining premature infants for ROP that's actually found to be a little more sensitive and specific than the current guidelines. The new GROP guidelines use 6 criteria, any one of which leads to an exam for ROP. And those 6 criteria are a gestational age less than 28 weeks, a birth weight less than 1,051 grams, 3 different measures of slow postnatal weight gain. So one of them is if a weight gain between between day 10 and day 19 after birth is less than 120 grams. The second is a weight gain between day 20 and 29 after birth being less than 180 grams. And the third is a weight gain between day 30 and 39 after birth that's less than 170 grams. And the last of the 6 criteria is the presence of hydrocephalus. So these weight gain measurements help to capture infants that have an initial birth weight that's higher and are of older gestational age who may still develop type 1 ROP.
It's so fascinating to me how even between when I graduated medical school and today, the studies are just rapidly progressing and increasing, and how we practice medicine changes so fast. So it's always really exciting. I mean, needless to say, we're in the coolest field, but it really is just so cool to see these things. All right, so now we know the screening criteria, we know the examination findings, we know the studies. How do we treat these babies?
Sure. So just to, again, summarize a little bit, because I know it's a lot of information. So we currently are screening infants with birth weights less than or equal to 1,500 grams and gestational age less than or equal to 30 weeks. We're beginning screening at about 4 weeks chronological age or 31 weeks postmenstrual age, whichever is later. And follow-up depends on the stage, the zone, and the extent of ROP. Extent meaning the number of clock hours. If type 1 pre-threshold or threshold disease is reached, then treatment options really include laser and anti-VEGF therapy. Laser has become preferable to cryo. It's associated with less treatment-related morbidity. And in my opinion, cryo is rarely used now unless laser is unavailable. And just one thing to note about laser treatment and injections, babies really should be monitored, especially during laser treatment. There's a risk of cardiopulmonary arrest. So a lot of the time it's done under anesthesia in an operating room or in the NICU with a team there that is monitoring the baby. Just a little bit about the anti-VEGF therapies. So another trial to mention is called BEAT-ROP. So that's bevacizumab eliminates the angiogenic threat of ROP. And that was a multi-center trial to assess intravitreal Avastin for zone 1 or posterior zone 2 stage 3 ROP with plus. And anti-VEGF injections, I think, have really changed the game for ROP treatment. They found that normal peripheral vascularization continues after treatment with Avastin or other anti-VEGFs, as opposed to laser, which permanently destroys the peripheral retina. One thing to note, though, is in the trials, recurrences can occur later with Avastin than with something like laser. So monitoring these infants long-term is super important. The other anti-VEGF agents, and just a couple of trials in case they show up on board exams, I personally use Avastin. That's what my hospital has. But the Rainbow trial tested Lucentis, and the Firefly and Butterfly trials examined the use of aflibercept, Eylea, which has actually just been approved for ROP treatment. If we reach stage 4 ROP, then surgery becomes really the only option. And in general, lens-sparing vitrectomy is preferred. Scleral buckling can be helpful. It is very difficult in very small eyes, and the eye is growing and the buckle will need to be ultimately removed depending on the age of the patient. So it's just something to keep in mind. In general, in stage 5 ROP, what we're trying to do with surgery is dissect off some of these preretinal fibrotic membranes. with the vitrectomy. And if a break is made, usually the prognosis becomes very, very poor. In general, in stage 4 or 5 eyes, only about a quarter of them remain attached at 5 years.
Yeah, it is very sad to hear about the severity of those stage 4 and stage 5 babies, but hopefully, as we continue to advance our knowledge, like we were just talking about, we'll be able to give them even better treatment options. Dr. Laura, thank you so much for this very, very helpful review. I feel like I will have to listen to this 3 or 4 times to drill those numbers into my head. And before we end the episode, I ask all of my guests if you could have dinner with one person from any time or place in the history of humanity, who would it be?
So, I actually, since starting medical school, my answer to this question is always Elizabeth Blackwell, who's the first woman to earn a medical degree in the United States. I just think her story is, I mean, she's super inspiring. Her story is really cool. She got rejected from every medical school except one. It was Geneva Medical College. This was in like the mid 1800s. The school doesn't exist anymore. I think it was absorbed by a SUNY school, but she was accepted as a joke, actually. The male classmates voted her in as a joke. And she did remarkably well, of course. And she was involved in healthcare for women. She opened the New York Infirmary for Women. She was a huge proponent of medical education for women. But interestingly, she also contracted a really terrible eye infection, which makes her even more interesting. Relevant to this lecture, when she was treating a neonate with what sounds like gonorrheal conjunctivitis, she was flushing the eye and got splashed in her own eye and ended up losing her eye and couldn't be a surgeon. So, but an inspiring woman, and would love to sit down and have dinner with her and hear her story.
I honestly think this is the first response where my jaw dropped. The listeners can't see us, but we're on video right now, and my jaw is on the floor. I actually did not know that about her eye
Yeah,
history.
yeah,
Wow, that I mean, it's incredible what you learn, but she really was a pioneer, and how lucky are we that there were women like her that were willing to pave the way so that women like us can sit where we are today. And hopefully we can do the same for the women that come after us, maybe with
absolutely.
a little less gonorrhea in the eye.
Yeah. No, absolutely. She was an incredible person, and I'm super grateful for all of her sacrifices and hard work.
Dr. Laura, thank you again so, so much for joining us today.
That was my pleasure. This was a lot of fun. Thanks for having me.